I sincerely thank the JIPMER RCC for inviting me for this talk. So I will be covering carcinoma nasopharynx in two sessions. The first session today we will discuss the introductory part, that is the symptomatology, radiological anatomy, staging, investigations, and the role of radiotherapy. And tomorrow we will discuss the evolution of chemoradiation and the target volume delineation. In my lecture, today or tomorrow, I will not be discussing about the OARs because that itself is a big topic. So that cannot be covered in two lectures. So I will be discussing the target volume delineation of the primary schema. Yes, thank you very much. So coming to the unique nature of carcinoma nasopharynx, this is a unique malignancy in head and neck, right? We know that all the head and neck malignancies, except the carcinoma nasopharynx and the HPV positive C oropharynx, is due to the tobacco or tobacco-related products. But in nasopharynx, we have a definite viral etiology, although other factors are there, like environmental factors and host factors are there, but there is the Epstein-Barr virus etiology. That is one different, unique nature of carcinoma nasopharynx. Second is there is a definite geographic distribution. The Southeast Asia belt is known for, that is the area there is a high incidence of carcinoma nasopharynx. And in India, it is in the northeastern states. There is a bimodal peak like Hodgkin's disease. Second peak is between 50 and 59, the first peak in the second decade. And the pathology, there is a WHO has come up with a pathological new separate classification for carcinoma nasopharynx. They came initially in 2005. They updated in 2017. Staging is different. We know that any muscle involvement in head and neck squamous cell carcinoma is a T4 disease. Bone involvement is also T4 disease. Whereas in the carcinoma nasopharynx, the muscle involvement is only T2 and bone involvement is only T3. That is staging difference. And nodes in the nodal staging, there is no subclassification for a N2A, N2B, or N2C in carcinoma nasopharynx. There is no subclassification of N3A and N3B in the nasopharynx. So, and the composite stage is also different. I will discuss that in detail. And carcinoma nasopharynx is the most common malignancy in head and neck site, which throws distant metastasis. It is a high chance of lymph node involvement and also the venous supply, and these contribute to the distant metastasis. The prognosis is better. In patients, even in patients who have a stage 4 disease, stage 3 and stage 4 disease, the 3-year overall survival is more than 90% with the present chemoradiation protocols. They have an excellent prognosis. And the treatment wise, it's mainly a non-surgical territory. Mainly treatment is with radiation or chemoradiation, because the backbone of treatment of carcinoma nasopharynx is radiotherapy. So the radiotherapy, it's purely a radiation oncologist territory. And if you look into the recurrence pattern, you know that if you treat a head and neck squamous cell carcinoma, most of the relapse occurs in the locoregional site, either in the primary site or in the nodes. Whereas if you treat a carcinoma nasopharynx, the most common site of relapse is not locoregional, it is distant metastasis. So this is unique for carcinoma nasopharynx and how it is different from other head and neck sites. So we'll be discussing under three headings today. And tomorrow we will discuss these two, the rest of the basic radiological anatomy, workup, 8 TNM classification, and if time permits, I will also discuss the evolution of radiotherapy. I will discuss about chemotherapy tomorrow, the chemoradiation protocols, and also the target delineation for tomorrow. So before discussing the radiological anatomy, we need to know the cross-sectional anatomy. This is a cadaveric view. So I want your attention. The whole picture, all presentation is based on this slide. So you need to know this is maxilla. Whether my mouse is moving, Can anyone? The mouse is moving. My mouse is. Yes. The mouse is moving. Yes. Okay. Thank you very much. So this is the pterygoid place, and you have this is the nasal cavity, vomer. This is the choana. You can see this is the maxilla. This is the pterygoid plates. You need to know this is the lateral pterygoid muscle, this is the medial pterygoid muscle, and two other muscles are there. This is called the levator velae palatae muscle, and this is called the tensor velae palatae muscle. These are the muscles. This is the opening of the eustachian tube, the torus tubaris, and posterior to the torus tubaris, you have a lateral pharyngeal recess. So this is the fossa of Rosenmuller. The most of the carcinoma nasopharynx arises from the lateral pharyngeal recess. So this is the most common site of the carcinoma nasopharynx. Then you have this is the parapharyngeal space. You can make out this space. This is the parapharyngeal space. You have the carotid sheath here, and in the carotid sheath, you have internal carotid artery, you have the jugular vein, and also the cervical sympathetic plexus. The artery lies more anterior and more medial. The vein lies more posterior and lateral. And the medial to the internal carotid artery, this space, this is the most common site of the retropharyngeal lymph nodes. Retropharyngeal lymph nodes I will discuss. This is the most common site of retropharyngeal lymph nodes. Then you need to know the prevertebral muscles. This is the longest capitis muscle. This is the longest capitis muscle. You have the longest collar muscle. This is the longest collar muscle. And this is at the caudal edge of the nasopharynx, because you can make out the vertebra. The caudal edge of the C1, caudal wedge of the C1 vertebra is the caudal edge of the C1 vertebra is the caudal limit of nasopharynx. According to the Gray's anatomy, the cranial limit of C2 is considered as the upper limit of oropharynx. So the caudal limit of nasopharynx is the caudal limit of C1 vertebra. So this is, if you know this cross-sectional anatomy, then definitely you can go forward. I will discuss few CT scans. First, an MRI, initially the normal CT scans. This is the pterygoid plates. This is the pterygoid plates. And you have the lateral pterygoid muscle. This is the lateral pterygoid muscle. You have the medial pterygoid muscle. This is the medial pterygoid muscle. Then you have two muscles, that is the levator velae palatae muscle and tensor velae palatae muscle. And it cannot be clearly made out in a CT scan. A levator velae palatae muscle and tensor velae palatae muscle. This is the styloid process which divides the parapharyngeal space into anterior and posterior compartment. The prevertebral muscles cannot be clearly made out in a CT scan, but MRI is very useful for that purpose. This is the opening of the eustachian tube, the torus tubaris, and posterior to the torus tubaris, you have the lateral pharyngeal recess. So this is the normal CT scan of nasopharynx. And we need to know certain spaces. I want to make things very simple. We need to know what is the pharyngeal mucosal space. This is the pharyngeal mucosal space, and this is the light green. This is the pharyngeal mucosal. Sorry, this space. This is blue. So this is the lateral pharyngeal mucosal space. And whenever a tumor which is confined to pharyngeal mucosal space, or tumor involves the nasal cavity or down into oropharynx, so whenever a tumor is spread beyond the pharyngeal mucosal space, this space beyond this, then it becomes a T2 disease. Involvement, this is a medial pterygoid muscle that we have discussed. This is the lateral pterygoid muscle. When a tumor which infiltrates into the pterygoid muscles, earlier it was T4. In all head and neck, it is T4. Exceptions are, one of them exception is nasopharynx, where medial pterygoid muscle involvement is only T2. Lateral pterygoid muscle involvement, this is the lateral pterygoid muscle, this is the lateral pterygoid muscle on opposite side, and that is also involvement, it only makes it T2. Earlier it was T4. When they analyzed the 5-year survival, it was found that the survival curves of patients who are receiving T4, T2, and tumors which involve the pterygoid muscles were hugging each other. So they have reclassified into T2 disease. But if any tumor which spreads beyond the lateral pterygoid muscle, this is the lateral pterygoid muscle, beyond that it becomes a T4 disease. So, and earlier it was the infratemporal fossa. That was the terminology we used. But now, when any tumor which spreads beyond the lateral border of the lateral pterygoid muscle, it automatically becomes a T4 disease. Now coming to the symptomatology. If any tumor which spreads anteriorly, this patient will have nasal symptoms like epistaxis, nasal blockade, nasal discharge. So this will be the symptoms when a tumor spreads anteriorly. When a tumor spreads, this is the parapharyngeal space. In a patient, the tumor spreads parapharyngeal space, and this is the retropharyngeal. This is the retropharyngeal. So any patients who have parapharyngeal space involvement, then this parapharyngeal space have the lower cranial nerve parts, lower cranial nerves, and the lower cranial nerves will be involved. So if you have 9, 10, 11, most probably due to a parapharyngeal space involvement or due to a base of skull involvement. Then when you have this tumor spreads laterally and involve the ear, then the patient can have serous otitis media. When the tumor spreads posteriorly to prevertebral muscles, like if you have the prevertebral muscles longus capitis or longus colli involvement, then the patient can have the torticollis. You can neck stiffness. Patient had difficulty in moving the neck. Then the prevertebral muscles are involved. If the patient has involvement of the pterygoid plates or medial or lateral pterygoid involvement, patient can develop trismus. So the trismus, looking at the radiology, you can say this patient have the symptoms. So this is important for you to analyze. And this is the parapharyngeal space. This is the normal parapharyngeal. It looks hypodense in a CT. You can say it is hyperintense in MRI. I will show that. It's a fat. So this is the normal parapharyngeal space. When a tumor spreads into parapharyngeal space, it becomes a T2. When the patient tumor spreads to prevertebral muscles, it becomes T2. I will show MRI based on that. And coming to this, I have already discussed. This is the pterygoid plates. Again, those who have come late, I am explaining again. You need to know that this is pterygoid plates. This is the medial pterygoid muscle, lateral pterygoid muscle. You have the tensor velae palatae muscle, levator velae palatae muscle. Then you have this is the lateral pharyngeal recess, the prevertebral muscles. You have the carotid sheath here. You have the styloid process, the parapharyngeal space, pterygoid. This is the nasal cavity. So it is difficult to delineate the prevertebral muscles in a CT scan, and subtle changes cannot be made out. For that to know whether it is T1 or a T2 due to the prevertebral muscles, definitely you need an MRI. If without an MRI, you will not be able to distinguish T1 bar T2 in an early disease due to involvement of the prevertebral muscles. This is, you need to know the certain spaces also. This is the masticator space. This is the masticator space. You need to know the masticator space involvement in an oral cavity disease is T4B. In a T4B, medial pterygoid involvement in a oropharyngeal carcinoma, HPV negative is T4A. Lateral pterygoid muscle involvement in HPV negative is T4B. Whereas in HPV positive disease, either it is medial pterygoid or lateral pterygoid, it is classified as T4. Whereas if you have a medial pterygoid or lateral pterygoid involvement in a nasopharynx, it is only T2. But any tumor spread beyond lateral border of the lateral pterygoid, it becomes a T4B disease. If you have a masseter involvement like this is a masseter muscle, this is a normal masseter. So if you have a normal masseter involvement, then it becomes a T4 disease. There is no subclassification of T4A or T4B in carcinoma nasopharynx. This is a parotid. Why you need to know parotid space? When you have a pharyngeal mucosal space involvement, it is T1. The parapharyngeal space involvement is T2. When you have a parotid space is nothing but the parotid gland. So this is the parotid. And if you have any deep lobe of the parotid gland, the deep lobe of the parotid gland is in close proximity to the parapharyngeal space. And if you have a deep lobe of the parotid is involved, automatically it becomes a T4 disease. So you need to know this. This is the parotid. If a parotid is involved, then it becomes a T4 disease. Coming to the MRI, the normal MRI, this is the parapharyngeal space. You have the pterygoid plates. The bone cannot be clearly made out in an MRI. The CT is the best for that. You have the medial pterygoid muscle, lateral pterygoid muscle. You have the opening of the eustachian tube, torus tubaris. You have the lateral pharyngeal recess, the prevertebral muscles, and this is the parapharyngeal space on the left side. And here you have the parotid. This is the parotid space. This is the masticator space in MRI. Coming to we will discuss now the sagittal view. In the sagittal view, we need to know we know that the boundaries of nasopharynx, superiorly it is the basis sphenoid. This is the sphenoid. I will show that. Beyond that, this is the basis sphenoid. Beyond this, the superior to that, this is the basi occiput that forms the posterior boundary. Basi occiput and the C1 vertebra. This forms the posterior boundary of nasopharynx. Here you have the opening of the eustachian tube, the torus tubaris. This is the nasopharynx. It is continuous anterior as nasal cavity, and it is continuing inferiorly as oropharynx. It is continuing. This is the soft palate. When a tumor in the nasopharynx extends into the oropharynx, the patient can develop a hot potato voice. So this is, and when you have a superior extension, it extends into the sphenoid sinus. Then beyond that, the patient can develop direct access to cavernous sinus through the foramen lacerum. I will show you that. So this is the normal MRI of the sagittal view of nasopharynx. This is the sphenoid sinus. This is the nasopharynx, and continuing inferiorly as oropharynx. And this is the soft palate. Anteriorly, it communicates with nasal cavity. Posteriorly, it is the basi occiput and the C1 vertebra. And the limit, the caudal limit of the nasopharynx is the caudal limit of the C1 vertebra. It may be slightly difficult for you to evaluate a coronal view of the MRI, but certain situations it may be very helpful. Know the early parapharyngeal space involvement. Can you mute, please? Thank you. Number one, to know the early parapharyngeal space involvement, the early intracranial extension. These are all better can be delineated in a coronal view. This is the normal pharyngeal mucosal space. This is the green one. This is the blue one, is the masticator space. This is the yellow one, is the parapharyngeal space. And this is a coronal view. So coming to the symptomatology, if a patient is having, say, extension into the nasal cavity, the patient can have the nasal symptoms, and it can also lead on to the orbit involvement, then the mechanical obstruction of the muscles, eustachian tube laterally, serous otitis media, and the parapharyngeal space involvement, it can lead on to the cranial nerve palsies, which I have already mentioned to you. Then the pterygoid muscles involvement. The patient can develop trismus. The retropharyngeal nodes or the prevertebral muscle involvement by the tumor, patient can develop neck stiffness. Inferior extent can cause hot potato voice, and the patient can develop the nodes. The nodes is the most common symptom of the patient presentation. If you look in different series, a series from Hong Kong, it may show slight difference compared to Singapore series, but this is from Hong Kong. The neck mass is the most common symptom, followed by nasal symptoms, and third is the ear symptoms. 20% of the patient can present with cranial nerve palsies, and straight away you can diagnose it as T4 disease. And if you look into the patients who present at distant metastasis, very low, is less than 5%. Patient can present with distant metastasis at presentation. Now coming to the next, the investigations. So any suspected nasopharyngeal carcinoma, if a patient is having nasal symptoms or patient is having cranial nerve palsies, facial pain, ear symptoms, then we know that especially in the two peaks, then you know that you are dealing with nasopharyngeal carcinoma. Never think that it is nasopharynx, nasopharynx alone. 85% of the malignant tumors in nasopharynx is constituted by nasopharyngeal carcinoma. But 15% is due to other factors. If you have 15%, you have other factors. Then the other malignancies occur in nasopharyngeal area are one, lymphomas. Among the lymphomas, diffuse large B-cell lymphoma. The intermediate grade lymphoma is the most common. The other is the adenoid cystic carcinoma with perineural invasion. Intracranial extension is very well known for that. Melanoma, then plasmacytoma, all other like all other tumors, rhabdomyosarcoma, all this can occur in this area. Plasmacytoma then. So we need to have an endoscopy and a biopsy. The imaging investigation of choice is the MRI from base of skull to root of the neck, and the MRI is superior to CT scan in certain situations. One, to know whether a prevertebral muscle involvement is present or not. Number one. Number two, if a patient is having a parapharyngeal extension, then intracranial extension, and to assess the extent of intracranial extension, MRI superior to CT scan, then perineural invasion. Therefore, these factors, MRI is superior to CT scan. Certain authors also mention that the for retropharyngeal nodes, MRI is superior to CT scan. So these are the areas where MRI is scores over. The distal metastatic workup is required for all patients with advanced disease, T3, T4, N2, N3, or undifferentiated histology. All patients need to have a distal metastatic workup. For that, either you can do a PET-CT in one shot, or you can go by, you can do an X-ray chest, you can do a bone scan, you can do an ultrasound. Much cheap way of doing a distal metastatic workup. That's also, we cannot categorically say that PET-CT is superior to other investigations. There is no hardcore data to say that, but generally PET scan is one of the indications. One of the indications for PET scan is a workup for carcinoma nasopharynx. Then if you are going for X-ray chest, bone scan, and ultrasound, in certain situations we have to do a CT thorax. If we have large nodes below the caudal edge of the cricoid cartilage, or any nodes in supraclavicular fossa nodes, or large nodes in the lower neck, it may be wise to consider CT thorax along with a bone scan and ultrasound of the abdomen rather than going for an X-ray. Blood counts, we need to have a BV titer. It is having a prognostic significance. Visual field testing, especially if a patient is having the 3, 4, 6 cranial nerve palsies are involved. Baseline audiometry, because of two things. One, because of the ear involvement, nerve involvement, or due to the patient is going to receive cisplatin. All patients should have a dental prophylaxis before considering radiotherapy or chemoradiation, depending on the stage. Then coming to the staging, T1 disease. Coming to the T1 disease, so we need to know what is T1. Tumors which is involving tumors confined to nasopharynx. That was earlier considered as T1 alone. Now, a tumors involving oropharynx or nasal cavity, it is T1. In most situations in head and neck, we know that the staging is based on the size criteria. In oral cavity, less than 2 centimeter is T1. Less than or equal to 2 to 4, it is T2. Whereas in nasopharynx, it is not based on the size criteria. It is based on the other sites involvement. If you have a glottic tumor extending into supraglottis, it is T2. Whereas in nasopharynx, going into oropharynx, is still T1. If you have a tumor in base of tongue extending into supraglottic larynx, is T4. Whereas a nasopharynx extending in nasal cavity is T1. So that is T1. I will show a few examples of T1. So you have I am again coming to this picture. That's a sagittal view. In this, you can see that the tumor extending into the oropharynx or tumor extending into nasal cavity, it is T1. It is a T1 disease. This is a diagnosis of exclusion because in an MRI, you can clearly make out. See, this is the prevertebral muscles. All the planes with the prevertebral muscles are intact. Can you make out? And the parapharyngeal space is also intact. That is why it is a T1 disease. The prevertebral muscles are not involved. The parapharyngeal space is not involved. The pterygoid muscles are intact. So it is a T1 disease. Again, I will show this is a soft tissue enhancement. You can make out in the right lateral pharyngeal recess. There is a small tumor confined to nasopharynx. That's a T1 disease. And even if you can, in this, you can make out the tumor is infiltrating into the posterior aspect of the nasal cavity, and it is still a T1 disease. Now, coming to the T2 disease, in T2, in the 7th TNM, it was in 7th and 8th, it is slight difference. So I will discuss what is the update. This is 7th. You can see that the tumors involving the parapharyngeal space or the carotid sheath. So this is the parapharyngeal space is considered as T2 disease. The prevertebral muscle was not included in the stage, and the pterygoid muscles was considered as T4. When they analyzed the data, it was found that the tumors involving medial pterygoid and lateral pterygoid, they have a good prognosis, and they should be subclassified as T2 because the survival curves were similar to T2 disease, and they have pre-stage the pterygoid muscle involvement as T2 disease. And they have added the prevertebral muscle. Now, the T2 is three factors. One, the prevertebral muscles, carotid sheath, then that constitute part of the parapharyngeal space. This is the parapharyngeal space, the carotid sheath and parapharyngeal space. Then the medial and lateral pterygoid muscles. For any tumor which spreads beyond the lateral border of the lateral pterygoid, I told you in the beginning, it becomes a T4 disease. So medial pterygoid and lateral pterygoid is only T2 and it is not T4. The prevertebral muscles, we have to be very clear because prevertebral muscles in T2 in nasopharynx is T2. The prevertebral muscle involvement in larynx and hypopharynx is T4B. Prevertebral muscle involvement is not included in the staging of oropharynx. So the examiner can ask you if the oropharyngeal, the prevertebral muscle is involvement is there, what is the stage? You have to say that it is not involved in the staging of oropharynx. If it is involving the knee, it is from a nasopharyngeal tumor, prevertebral muscles are involved, it is a T2. Whereas in the lower down, in larynx and hypopharynx, prevertebral muscle involvement, it becomes a T4. Now coming to, that is the difference between the 7th and the 8th. I will show you examples for each. Suppose you have this is the typical MRI shows it's a T2. This, can you make out the prevertebral muscle? This is the prevertebral muscle involved. Here on this side, on right side, it is intact, whereas the prevertebral muscle is infiltrated by the tumor. The parapharyngeal space is involved. The medial pterygoid muscle is involved. So all the three factors: the prevertebral muscle involvement, the parapharyngeal space, and medial pterygoid involvement is there. It is a T2 disease. Now, coming to the next, this is again the parapharyngeal space is involved and the prevertebral muscle is also involved. It is a T2 disease. And I want to discuss this CT scan also. This is also a classic T2. This is how it will look a normal right parapharyngeal space. Sorry, this is the right parapharyngeal space. This is the right parapharyngeal space. This is the opening of the eustachian tube, the torus tubaris. Posterior to the torus tubaris, you have the lateral pharyngeal recess, the right lateral pharyngeal recess. On left side, it is obliterated, it's replaced by the tumor, and it is infiltrating the prevertebral muscles. Also, the obliteration of the parapharyngeal space, and also involvement of the pterygoid muscle. And you up to the pterygoid plates, the medial pterygoid seems to be infiltrated and very closely affecting the lateral pterygoid muscle also. So this is a T2 disease, and it is not T4. How to contour these tumors will be discussed tomorrow. Now coming to, so muscle involvement in all head and neck sites, like if you have an oral cavity disease, if muscle is involved, say masseter involvement from an oral cavity disease, tubercle complex tumor, this is a T4 disease. Whereas medial pterygoid and lateral pterygoid muscle, it is only T2 in carcinoma nasopharynx. Now coming to the bony involvement. T3 nasopharynx means classical involvement of bony involvement. Whenever you have a bony involvement, like a skull base involvement, clivus destruction, pterygoid plate destruction, if you have a pterygoid plates are destroyed, or extension into maxilla, sphenoid sinus, then it all constitutes, it is a T3 disease. So bone involvement is T3 disease. This is the clivus. This was a nasopharyngeal carcinoma. Actually, this was patient presented with meningitis. It's one of my patient treated in 2013. And this patient presented with meningitis, and due to clivus destruction. And this while on workup, then from the hospital it was diagnosed after when he was undergoing treatment for meningitis. And this patient was done a CT scan. Then it was the clivus destruction was identified. Biopsy showed undifferentiated carcinoma and referred to us. So this is a T3 disease because a clivus destruction is present. And if you have a C1 destruction, sometimes C1 destruction can occur. It is also a T3 disease. The base of skull involvement, it becomes a base of skull involvement is there. It becomes a T3 disease. You have base of skull involvement and you have the sphenoid sinus involvement. This is the sphenoid sinus involvement. This is a pterygopalatine fossa. This is a pterygopalatine fossa. Okay, I will discuss that. That is very important for contouring pterygopalatine fossa. Then coming to we need to know the foramina, because when a base of skull is involved, it becomes T3, but when the cranial nerve is involved, it becomes T4. So which are the foramina? Because we need to go back to our head and neck MBBS days. This is the optic canal which shows the optic nerve and ophthalmic artery. This is a superior orbital fissure. The structures which pass through the superior orbit transmit are the 3, 4, 6 cranial nerves, the oculomotor, trochlear, abducent, and the first division of the fifth cranial nerve. That is the ophthalmic nerve. This is a superior orbital fissure. This is a foramen rotunda, which transmits the maxillary nerve. The foramen ovale transmits the mandibular nerve, which is the third division of the fifth cranial nerve. And if suppose a patient is having, and this is the lacerum, foramen lacerum, you have the foramen spinosum. I will show you how to read that in a CT scan in the later slides. So the foramen lacerum is the most weak. This is the weakest part of the base of skull. It gain access and spread anteriorly, and it gain access to the cavernous sinus. Then this is the groove for the carotid artery. This is the groove for the carotid artery, and on this side, this is the groove for the carotid artery. So I will show if you take a cut at the level of the cavernous sinus, the structures which are involved are 3, 4, 6 cranial nerves and the first and the second division of the fifth cranial nerve. Then the second division of the fifth cranial nerve is this is the foramen rotunda and foramen ovale. If a cavernous sinus is involved, most probably the mandibular nerve will be spared, but the maxillary nerve will be involved. So I will show you that. So this is 3, 4, 6 cranial nerve. The first division which enters into the superior orbital fissure. Then this we have seen here. The second division occurs into the foramen rotundum, and third division occurs to the foramen ovale. So the third division will be spared in the cavernous sinus involvement. This is the carotid artery. 3, 4, 6, first and second division of the fifth cranial nerve, and the V3, the mandibular nerve, which is through the foramen ovale, will be spared in a cavernous sinus involvement. Now coming to the other foramina, why it is important to know, because the jugular foramen, because this can also have, we need to know the jugular foramen, which is very important. Then the 3, 4, 6 cranial nerves are due to the cavernous sinus involvement, and lower cranial nerve palsies are mainly due to the base of skull destruction or due to the parapharyngeal space involvement. Then 9, 10, 11 cranial nerves. So this is the jugular foramen which transmit 9, 10, 11, and also the jugular bulb. And the hypoglossal canal, this transmit the 12th cranial nerve. Now we are coming to the radiological anatomy of the base of skull. First, I will discuss the pterygopalatine fossa. So this is the pterygopalatine fossa, which is pterygopalatine fossa, which gains access, which is to the middle cranial fossa. This is the middle cranial fossa through the foramen rotunda. So the foramen rotunda. So there is, if you have a tumor in the pterygopalatine fossa, it can access to middle cranial fossa through the foramen rotunda. So that we need to know. Then it transmits, it communicates with the infratemporal fossa. This is the infratemporal fossa. This infratemporal fossa, this is called the pterygomaxillary fissure. This is the pterygomaxillary fissure. They gain access or transmit through the pterygomaxillary fissure. Then in the pterygopalatine fossa communicates anteriorly. It extends to the orbit. So this is at a slightly lower cut, superior cut. It transmits with the orbit, and it through the orbit anteriorly through the inferior orbital nerve and nasal cavity. It extends to the nasal cavity through the sphenopalatine foramen. You have the sphenopalatine foramen. It transmits communicates with the pterygopalatine fossa, communicates with the nasal cavity through the sphenopalatine foramen. It also communicates with the oral cavity through the greater palatine canal or less. So this mainly we need to know infratemporal fossa, the middle cranial fossa, the orbit, and the nasal cavity for communications of pterygopalatine fossa. Then you need to know the foramen. This is the carotid canal. You can see this is I will show you that later. This is the pterygopalatine fossa on this part. This is the carotid. You have the carotid canal here, then the foramen lacerum here, foramen lacerum. Then pterygopalatine fossa is connected to the this I have already discussed. Now we need to know the foramina in a CT scan. How to identify foramina in the CT scan? This is the superior orbital fissure. This is a foramen ovale. Why you need to know foramen ovale? Because it is foramen ovale is more lateral. This is for foramen ovale compared to foramen rotunda is more lateral because this has to be part of this CTV P2 in carcinoma nasopharynx that I will show you tomorrow. Then you have this foramen spinosum. This is foramen spinosum. Very rare to see foramen spinosum in a CT scan. You have the foramen lacerum here. You have this is a foramen lacerum. This is the weakest part that I will show. I have told you. This is the carotid canal. This is the carotid canal. This is the jugular foramen. I will show you. I have another slides for jugular foramen. So that this is the carotid canal. This is the foramen lacerum. I am explaining once again. This is the foramen ovale. You have the foramen rotundum that I will show you. I have already shown one. Then I will show. This is the foramen ovale. You have to contour both sides of foramen ovale. This is the foramen lacerum. This is the foramen lacerum on right side. This is the foramen, foramen spinosum on the right side. This is the foramen spinosum on the left side. This is the, you need to know, this is the foramen lacerum. This is on right side. This is left side. It is in close proximity to the carotid bulb. This is a foramen ovale on both sides. Now coming to the T4 disease. The T4 disease, T4, 20% of the tumors, in tumors, we can diagnose T4 in the clinic itself because 20% of the patients present with cranial nerve palsy. If you have cranial nerve palsies, in second is intracranial extension, involvement of the cranial nerves. Hypopharynx is very rare. In last 15 years of my experience in head and neck, I am yet to see a nasopharyngeal carcinoma with hypopharyngeal involvement because it is rare. Orbit involvement I have seen, I will show you. Parotid gland, because beyond the parapharyngeal space, when a parotid space is involved, then it becomes T4. So this is the parotid, becomes a T4. The orbit involvement I will show you, that is T4. Then any tumor beyond the lateral border of the lateral pterygoid muscle that have been repeating many times. So this is also T4 disease. The parotid gland involvement is a T4 tumor beyond the lateral border of the pterygoid muscles. Now I will show you one by one. This is the pterygopalatine fossa and tumor involving into the infratemporal fossa extension to the pterygomaxillary fissure and gaining access to the middle cranial fossa through the foramen rotundum. Can you make out this? An extension into the maxilla. It is also T3 disease. It is not T4. But now coming to the T4 disease. This is a coronal view. You can see this is the cavernous sinus is involved. This is the cavernous sinus involvement. The patient had the lower cranial nerve pulses, 3, 4, 6. Again, this patient had sphenoid sinus, so it is T3, but the patient is having middle cranial fossa, it is T4. This is intracranial extension is present, sphenoid sinus involvement is there from a tumor in the nasopharynx. It's a T4. And this is a MRI showing in involvement of the parotid gland. This is a parotid gland. So this is also parotid gland is involved by the tumor. And this is a T4. Now coming to the intracranial extension through the foramen rotundum. This is a foramen rotundum. Through the foramen rotundum from the pterygopalatine fossa, the tumor is gaining access to the intracranial part. This is a T4 disease. This is a T3 disease. Now coming to this patient, this is one of my patients who received chemoradiation in 2014, coming for yearly follow-up now. This patient presented with proptosis. Can you make out this is a proptosis with ptosis, 346 cranial nerve palsies. This is intracranial cavernous as typical cavernous sinus involvement. This closely affecting the brainstem and also involving very closely. If you observe, you can also involving the orbit. This is a T4 disease. This is the normal groove of the normal enhancement of the carotid artery on the right side. And this side, this tumor is this is a very massive tumor. This 2006 patient was in 2006. I think the initial years of my career. And this patient had a pterygoid plate destruction. The prevertebral muscles are involved. The parotid gland is also, the deep lobe is involved, lateral to the lateral pterygoid muscle. So due to the parapharyngeal space involvement, it is T2. The prevertebral muscle is T2. Destruction of pterygoid plate is T3. Involvement of the parotid gland and the tumor which spreads beyond the lateral part of the lateral pterygoid is T4. So in conclusion, it is a T4. Now coming to the nodes. Now the second part of the staging is nodes. The most involved, most common is, but we know that whenever we discuss about carcinoma nasopharynx, you always think about retropharyngeal nodes. Retropharyngeal lymph nodes are the characteristic lymph nodes of carcinoma nasopharynx, but they are not the most common. The most common involved lymph nodes are level 2 lymph nodes. This is 94%, this is 80%. Most commonly involved are level 2, level 3, level 5A. Why you need to know? Because even if a patient is having an R0, is N0, you need to give retropharyngeal nodes level 2, level 3, level 5A. You need to know at least this area to a minimum dose of intermediate risk choline. That's around 60 gray. So that is why that I will discuss tomorrow. Then you need to know the majority of nodes are involved are level 2, level retropharyngeal nodes, level 3 and level 5B. This level 5B and level 4 nodes are less. Then how you describe the, earlier it was in the 7th classification that I will discuss now. What is the update? If you look into the lymph node metastasis, we know that the size criteria for a cervical lymph node to be involved, we need to say it is an involved node radiologically. The short axis diameter should be more than 1 centimeter. That is, the short axis diameter should be more than 1 centimeter for a cervical node. But for retropharyngeal node, it is 5 mm. So if a retropharyngeal node it is 5 mm or a node is having a necrosis, then you have to consider it as an involved node. So based on the new contouring guidelines, what are the criteria to say that this is an involved node? One, any node with a central necrosis. Number two, any node with extracapsular spread. Third is short axis diameter of more than 1 centimeter for a cervical node. That the criteria is 5 mm for retropharyngeal nodes. Other is, the last one is cluster of 3 or more lymph nodes of borderline in size. But suppose if you have say 8 mm or 7 mm and 3 or 4 of them are clustered together, then you have to think that this is an involvement from a carcinoma nasopharynx. Now I want to discuss retropharyngeal nodes. In retropharyngeal nodes, in slide this one, in detail, we need to know that the cranial, this is the uh, retropharyngeal nodes. It extends from the C1 vertebra. It extends from the C1 vertebra, and earlier it was base of skull. Whenever you have a retropharyngeal nodes, you need to think that it is from nasopharynx, posterior pharyngeal wall, or from an oropharynx. It is the this is the cranial limit. The caudal limit is the cranial edge of the hyoid bone. The from the C1 vertebra, from the C1 vertebra to the caudal edge of the cranial vertebra. This is the hyoid bone. That also forms the superior limit of level 5 nodes. Then the cranial limit of level 5 is the caudal limit of the retropharyngeal 7A nodes. That is the cranial limit of the hyoid bone. So this extends from C1 vertebra to the cranial limit of the hyoid bone. Then you need to know that this is that I have discussed already. The lateral limit. The lateral limit of the retropharyngeal node is the medial edge of the internal carotid artery. This is the lateral limit. Posterior limit is the prevertebral muscle. This is the anterior. I will show you. This is the anterior limit. So this is the prevertebral muscles. This is the prevertebral muscles. The lateral limit is the medial edge of the internal carotid artery, and the anterior limit is the fascia covering the pharyngeal constrictors. This is the fascia covering the pharyngeal constrictors. So that forms the anterior limit of the retropharyngeal. And medial is, earlier it was midline, but a line parallel to the lateral edge of the lungs capitis muscle. It is very difficult to delineate that image. So this is the retropharyngeal lymph nodes. Even if the patient has both retropharyngeal area, we have nodes, both retropharyngeal nodes are involved. That is on right side and left side, and it is only N1, provided the size of the node is less than 6 centimeters. So bilateral retropharyngeal nodes, it is N1. Okay, it is not. This is the internal carotid artery. You can make out this is medial to the internal carotid artery. I have been telling you that. So this is a retropharyngeal node. So the lower cranial nerve palsy can be due to parapharyngeal space involvement or due to retropharyngeal nodes. Retropharyngeal nodes also can cause neck stiffness. Okay. So five size criteria that I have discussed you. And suppose that the tumor is on right side and nodes are seen on the opposite side. Whether is it still N1? Yes, it is N1 only. This is, you can see that the tumor it's a T1 disease on right side. You have an N1 node here. It is N1. So this is N1 on the other side. But still, there is no concept called ipsilateral or contralateral in nasopharynx. It is called unilateral or bilateral. If you have, okay, so I will show you again. Can you tell me whether my mouse is working? Can you tell me whether my...
Yes.
Yes, sir. Yes, sir.
I will take a laser pointer. Okay, so this is the retropharyngeal nodes. Okay, and you have a tumor on the other side, but still this is only an N1 disease. On this patient, the same patient, on the lower cuts, you can see this is a retropharyngeal node, and patient had a level 2 node. Multiple nodes on one side. It is called on one side, that is called unilateral. It is N1, provided two things. One, there is no node more than 6 centimeter. Automatically it becomes N3. Or the patient should not have any node below the caudal edge of the cricoid cartilage. That I will show you later. In these two situations, it becomes N3. Otherwise, it is a N1 node. Now coming to the next. So now you have single node or multiple nodes on one side. It becomes one side, it becomes N1. Retropharyngeal nodes, bilateral, it is only N1. So if you have unilateral Mets or retropharyngeal nodes, 6 centimeter or smaller, above the caudal border of the cricoid cartilage, single or multiple, then it becomes only N1. Now you have multiple nodes. It's again N1. I have shown you. Multiple nodes, it is N1. And any node, if you look into the composite stage, the moment the patient is having a node, it becomes a T2 disease. Sorry, it becomes a stage 2 disease. If you have a T2N1 in a HPV positive oropharynx, it is only stage 1. Whereas if you have an N1 node in nasopharynx, it becomes stage 2. If you have N1 node in head and neck squamous cell carcinoma, it is stage 3. That is the difference between HPV positive oropharynx, the nasopharynx, and the common squamous cell carcinoma. Now coming to the next part, it is the N1 that we have seen. Bilateral nodes. If you have bilateral nodes, it becomes N2 disease. And you have bilateral nodes, but it should be above the caudal edge of the cricoid cartilage, and none of the nodes should have a more than 6 centimeter. It becomes N2 disease. And if you have an N2 disease, automatically it becomes a stage 3 disease. It's bilateral nodes. It is not contralateral node. We will never use the terminology contralateral node. We will use the terminology contralateral node even for HPV positive oropharynx. But we never use the terminology called contralateral node in nasopharynx. It is unilateral or bilateral. So any N2, it becomes stage 3. And there is no N2A, N2B, or N2C for carcinoma nasopharynx. Now coming to, you can see multiple nodes on both sides. It is, you can see that it's at the level of level 2. This is an multiple nodes. It's an N2 disease. Again, you have multiple nodes. This is at the level of the level 2 because you can see a hyoid bone there. Up to the caudal edge of the hyoid bone, it is level 2. You have multiple nodes here. The multiple nodes on this side, on this side. So it becomes a N2 disease. It becomes a bilateral, it is N2, and it is a stage 3 disease. And this is at the level of the level 3. You have multiple nodes on both sides. This is at the level of the level 3. If you have any node at the level of level 4, means below the caudal edge of the cricoid cartilage, it becomes a N3 node and it becomes a stage 4. Next is N3. Any node above 6 centimeter, automatically it becomes an N3 disease. Then it becomes a stage 4 disease. And again, there is no subclassification for N3, that is N3A or N3B for carcinoma nasopharynx. Any node below the caudal edge of the cricoid cartilage, irrespective of the size, even if you have 1 centimeter node, 1.1, you feel that it is radiologically involved. A node is below the caudal edge of the cricoid cartilage. It means at the level of the trachea. Means the caudal edge of the cricoid cartilage forms the caudal edge of level 3 node. Any node below that, it becomes automatically it becomes a N3 node. That is a slight difference between 7th classification TNM and 8th TNM. 7th TNM, it was any node involving supraclavicular fossa, it was considered as N3 node. So how you calculate supraclavicular fossa? You draw a line from sternal end of the clavicle to the point where the neck meets the shoulder. So that becomes any node in this triangle, it becomes an N3 disease. That was the criteria. And that is in 7. But in the 8, it is any node below the caudal edge of the cricoid cartilage. The caudal edge of the cricoid cartilage is classic for two things. One, it is the limit between level 3 and level 4 node. Number two, it is the level between level 5A and 5B. The 5A and 5B is also classified at the level of the caudal edge of the cricoid cartilage. Any node in the posterior aspect below the caudal edge of the cricoid cartilage, it is a 5B node. So that is 5A and 5B. So you can see this is trachea. So at that level, you see a node. Can you make out this node? And this is an N3 size is not more than 6 centimeter. The size is immaterial. You have to say that it is a radiologically involved based on the size. Right. Now coming to the next slide. Now we need to know what is the difference between nodal stations of nodal staging of squamous cell carcinoma of head and neck, HPV positive oropharynx, nasopharynx. And generally you are all confused. That's I want to clarify this with this slide. If you have few first year students are there. If you have say N1 node in an oral cavity, larynx, hypopharynx, HPV negative oropharynx, it should have three criteria. One, it should be single node, ipsilateral, and less than or equal to 3 centimeter. It becomes an N1 node. It becomes a stage 3 disease, irrespective of the. So suppose if you have two nodes, 1B and level 2, it becomes N2 disease, N2B, and it becomes a stage 4 disease. If you have multiple nodes on one side, and even if the node is below the caudal edge of the cricoid cartilage, even HPV positive oropharynx, it is only N1. And if it is only a T1 or a T2, it becomes a stage 1 disease. So that is the difference between staging of HPV positive oropharynx and nasopharynx. HPV negative oropharynx, oral cavity, larynx, hypopharynx, multiple nodes on one side, it becomes a stage 4 disease. You have and in nasopharynx, it becomes an N3 disease because any node below the caudal edge of the cricoid cartilage, it becomes an N3 disease, and automatically it becomes a stage 4 disease. Okay, so that is the nodal staging. Yes, coming to the next slide. Now, N3 is more than 6 centimeter, it becomes an stage 4A disease. And we need to know that N3 in head and neck squamous cell carcinoma is classified into N3A and N3B, and it becomes a stage 4. In nasopharynx, it is stage 4 disease. In HPV positive oropharynx, it is only stage 3 because and any stage 4 is a distant metastasis in HPV positive oropharynx. In head and neck squamous cell carcinoma oral cavity, HPV negative oropharynx, larynx and hypopharynx, the stage 4 is divided into stage 4A, 4B, and 4C. Stage 4C is distant metastasis, stage 4B is T4B or N3 disease, and stage 4A is T4A or N2 disease. In nasopharynx, It is divided into stage 4A and 4B. There is no stage 4C for carcinoma nasopharynx. Stage 4A means it is T4 or N3 disease. There is no subclassification for T4A and T4B in nasopharynx. And there is no subclassification for N3 or N3A into or N3B. And any T4 or N3, it becomes stage 4. Stage 4B is distant metastasis in carcinoma nasopharynx. There is no stage 4C in carcinoma nasopharynx. I think it is very clear to you. Next is, now I am putting the composite stage. T stage 1 is T1 and 0. The moment the patient is having a node, it is stage 2. So it is T1 N1, T2 N0, and T2 N1. It is stage 2. I will discuss this. Is very important for tomorrow's session because the evolution of radiotherapy and whether you need to give chemotherapy for stage 2, that's a matter of debate that we will discuss tomorrow. For that, you need to know the proper staging. So today, you have this material with you. You go through this, then come prepared for tomorrow's class. Then only you will be able to understand the contouring and the evidence properly. T3 is T3 or N2, that is stage 3 disease. T4 or N3, it becomes stage 4A. Any distant metastasis, it becomes stage 4B, and there is no stage 4C in carcinoma. Yes. This I have already discussed with you, so we will skip. Now, the key changes in carcinoma nasopharynx is one, changing the medial and lateral pterygoid muscle from T4 to T2, adding prevertebral muscle involvement as T2, replacing the supraclavicular fossa with the lower neck, that is defined as extension below the caudal border of the cricoid cartilage, and the N3A and N3B has been merged together as N3, and T4 or N3 is stage 4A. Now it was stage 4B earlier. Now it has become stage 4. This is the main staging. Now coming to the WHO classification for CN nasopharynx, that's a pathological classification. Type 1 is keratinizing squamous cell carcinoma. It is rare and it is mainly due to smoking. Non-keratinizing is the most common. It is differentiated and undifferentiated. Most of them, it is undifferentiated. You need to have an immunohistochemistry whether the cytokeratin is positive or not. And type 3 is basaloid. This constitute less than 5% of basaloid squamous cell, and type 3 less than 3%, less than 5%. And most commonly, it is type 2, either type 2A or 2B, that is differentiated non-keratinizing carcinoma or undifferentiated carcinoma. I think it is almost 8 o'clock. I will take few questions, then we will take the treatment tomorrow. I was planning to discuss the radiotherapy part, but it is almost 8 o'clock. So I will take the questions now. Never ask any questions regarding contouring or anything because that will be covered tomorrow. Kindly ask me about the staging, radiological anatomy, investigations.
Thank you, sir. That was a wonderful session. We have a few questions, sir. Why does nasopharyngeal cancer have a bimodal age distribution?
Yeah, this is again, it is not clearly defined. Actually, there are some conflicting data regarding that. Same question is applicable for Hodgkin disease also. If it's certain tumors, we are coming across a bimodal peak. So in nasopharynx, we have a bimodal peak. The age group which is affected are this. So we have no hardcore say that this because of this particular reason, this is having a bimodal. The gold standard investigation for nasopharyngeal carcinoma, the gold standard investigation is MRI. If you have an MRI, then the MRI is the investigation of choice. From basis for MRI is the investigation of choice for the nasopharynx and oropharynx. For larynx and hypopharynx, we presume that an oral cavity, we presume that it is the CT scan. In oral cavity itself, in gingivobuccal complex tumors, it is CT scan. For tongue and floor of mouth, it is MRI investigation. Do we need to have a metastatic workup or a T1 or a T2 disease? Yes, that's a very good question. Even I have been confused with this. If you have a T1 and a T2 disease with an N1 disease, whether we need to have metastatic workup. So again, in different clinical trials, whether they have done a metastatic workup in endemic areas, what they say is that okay, this patient should have a metastatic workup. And if you have an undifferentiated histology, even in a patient is having undifferentiated, even if the patient is having undifferentiated histology, and if it is a T1 or a T2 disease and early nodal involvement, that patient should have a distal metastatic workup. The extracapsular extension in nodal staging is not included for two things in head and neck. One is for carcinoma nasopharynx, and second is in CA oropharynx, which is HPV positive. In HPV positive, even if the patient is having extracapsular extension, it is not considered as N3B. That is why N3B is absent in CA nasopharynx and in HPV positive CA oropharynx. Any role for PET scan? Yes, its role for PET scan is there because the PET scan helps in distant metastasis and in one shot, especially in patients who have advanced disease. These are one of the indications for PET scan. The three classical indications for PET scan in head and neck are: one, distant metastatic workup for a carcinoma nasopharynx; number two, the workup for a MU, a metastatic neck node of unknown primary; and third is to evaluate whether the patient require a neck dissection UK based on the UK PET trial. That is whether you need to go for a planned neck dissection after chemoradiation for a oropharynx, larynx, or hypopharynx, or whether you trust your PET scan to decide the patient can be put on a surveillance program rather than taking the patient for a neck dissection. GT upwards, should we go for because the distant metastasis is mainly due to the nodal involvement. That is one of the reasons why the level of the lymph node involved becomes an independent criteria for the nodal stage. If we have a laryngeal tumor, the patient is having a level 4 node. Okay, it is considered, we will not change it as upstage to N3 node. But in nasopharynx, if any node at the level 4 node, then we have to consider it as an N3 disease. In such patients, if we are not going for PET CT, then you have to do a CT thorax. Ambiguous node, nodes are restricted. Sometimes you have ambiguous nodes.
So we have a few more questions on imaging, sir. There's one question asking about the advantages of MRI over CT scan for staging nasopharynx.
Yeah. That in the primary, if you want to stage T1, differentiate between a T1 and T2 based on prevertebral muscle involvement, then parapharyngeal space involvement, then the MRI is the investigation of choice. If you have a base of skull involvement, suppose if you want to know the sphenoid sinus involvement, clivus destruction, C1 destruction, CT is the investigation of choice. Suppose if you have a perineural invasion, if you have a pterygopalatine fossa tumor involving into the foramen rotundum through foramen rotundum, gaining access to middle cranial fossa, MRI is the investigation of choice. If you want to know the extent of intracranial extension, like cavernous sinus involvement, and tumors very closely abutting the brain stem, MRI is the investigation of choice. And the retropharyngeal, some series have shown that the retropharyngeal nodes are also picked up better in an MRI rather than in CT.
What is the role of PET MR? If both are available, is PET MR better than a PET CT?
That is, PET MR is evolving. PET MR is evolving. I won't say this is the investigation of choice as of now. It is still evolving. It is evolving. That may be the future. That may be the future. Promising to you.
So is there any situation where you would not do an MRI in case of CA nasopharynx
Okay.
in the initial evaluation?
So I will give you a clinical scenario. Suppose if a patient is having a T2 disease, okay, and patient is having a node, it's a CT2N1 disease. And this patient had an CT scan done outside, and the patient comes with the clinic, and you are not confused about whether the patient needs only radiotherapy or chemoradiation. You are pretty sure that this patient requires chemoradiation. In that situation, and if the patient cannot afford, the patient is no base bony involvement is there, you are not suspecting any intracranial extension, then I may resort, okay, I may not because we will do a repeat CT when we do the CT simulation. So I may not. Practically, I'm saying. But if my colleague says that no, an MRI is the investigation of choice, and okay, all patients, even this patient should need an MRI. Okay, then he or she is also right. So practically speaking, if the patient have a small oleum disease, no other signs, we can delineate the tumor pretty well. Okay, that's fine. But I'm not saying that this is the way to go. MRI may be the investigation of choice.
So we have a doubt asking that we often find it difficult to identify the foramina in a simulation CT scan, which is usually done with a neutral neck extension.
Yeah.
Is there any way to take a CT scan in a particular way so that this foramen can be easily identified? And do you suggest thinner CT slices?
It is a problem everywhere. In neutral position, it is difficult. In that situation, we have to be a little more liberal. That I will show you tomorrow.
Okay, so do thinner CT slices help in the neutral neck position?
Yeah, thinner slices, CT slices will be very good. That is one of the way to solve that.
So we have a few requests from students to repeat retropharyngeal lymph node space and neck spaces in the axial section.
Okay, initial part now.
Yes, sir.
Okay, I will do that. Wait. Yes, pieces. Okay. So I think this one, right?
Yes, sir.
Okay. So we need to know that this is the pharyngeal mucosal space. This is the pharyngeal mucosal space. Okay, if any tumor which is confined to the pharyngeal mucosal space, then it becomes a T1. This is the masticator space. The masticator space is by the bone, masseter, medial pterygoid, and lateral pterygoid. So this is the masticator space. This is the parapharyngeal space. This is the parapharyngeal space. And the parapharyngeal space, this is the anterior compartment. This is the posterior compartment. And this is whole together, we will say it is parapharyngeal because this area, the carotid sheath, is also the posterior part of the parapharyngeal space. This is the prevertebral muscles. Prevertebral muscles, this space is called the prevertebral space. So tumors involving the parapharyngeal space or the prevertebral muscle, prevertebral space is T2. If a tumor involves into the masticator space, infiltrates this area, it becomes T2. Whereas if it goes beyond the prevertebral muscles, parapharyngeal space, or the masticator space, that means beyond that, it becomes a T4. This is the T4 disease. In the masticator space itself, any tumor that spreads beyond the lateral border of the lateral pterygoid, it becomes a T4 disease. Okay, I think I'm clear.
Yes, sir.
Okay.
So why is the nodal staging and also the primary staging different for CA nasopharynx as compared to other head and neck squamous cell carcinomas?
Yeah, that is because whenever you look into the staging, suppose if you look into the staging of a P16 positive CA oropharynx or nasopharynx, we know that even if the patient is having multiple nodes on one side, then the survival of that patient is very good. Suppose if you have a stage 2 disease and multiple nodes are there, then if a patient is having N2 or N3, then still, if a patient is having N2, it becomes a stage 3 disease. If the patient is having N3 disease, it becomes a stage 4 disease. Still, this patient is having a very good prognosis. Still, but that is one of the reasons why even if a patient is having multiple nodes in CA, a P16 positive CA oropharynx, it becomes stage 1, or it is stage 2 for in carcinoma nasopharynx. Means T2N0, say if you have an oral cavity disease, stage 2 disease, if you treat the patient, the 5-year survival is around 70 to 80%. But that is applicable for even for nasopharynx, those who have nodes also. If you have a stage 2 nasopharyngeal carcinoma, the 5-year survival is maybe a little higher, maybe better. And that this with the new the IMRT and the new there is a benefit in terms of using IMRT in terms of locoregional control and also improvement in survival that we will discuss tomorrow. In that, and also if you introduce some form of induction chemotherapy, definitely there is an improvement in survival. So all this together, when they analyze every 5 years they are analyzing this data, that is why one of the reasons why they stage. Earlier, the N3 disease was classified as a stage 4B in carcinoma nasopharynx, that it becomes a stage 4 disease. And earlier, that is how even in multiple node positive in P16 disease, oropharynx, it is a stage 1 disease.
So we have a few questions about the EBV titer.
Okay. So if it is mandatory or not, it is having a prognostic significance. Number one. Number two, if whether that should be the guide for deciding adjuvant treatment, that I will discuss tomorrow, because there is a few clinical trials. One clinic phase 3 trial has been published from Hong Kong, and the other is underway by the NRG, evaluating the role of EBV titers. That I will discuss tomorrow.
So how do we identify perineural invasion on an MRI?
Okay, so that also I will try to discuss tomorrow.
All right. I think so there are a few more questions. Is visual field testing important before starting radiotherapy in all patients?
In all patients, it may not be required. But if you have a 3, 4, 6 cranial pulses, okay, then then it may be wise to do that.
Yeah. All right, sir. That's all the questions we have. So that was a wonderful session. I would like to hand over to Dr. Jagadesan, additional professor.
Thank you, sir.
Thank you very much, Dr. Cessal. It was a comfortably paced presentation, and I hope all the participants would have understood very well the entire sequence, and you have set the stage for them to understand the contouring principles, which we will be covering tomorrow.